Assalamu alaikum wa rahmatullahi wa barakatuh. A very good day, good evening, wherever you are in the world, across the lands and over the beautiful seas. Thank you so much for joining us in this edition of Your Health and Wellness Show. Stay with me for the next 60 minutes as we talk about joints, arthritis, pains, muscles, bones is the discussion that we're having for this week. Inshallah, please, we love your interaction. So send them through via our social media pages and also comments and questions and queries through to the show so we can highlight today's topic and hopefully send through your niggling joint questions. We have orthopedic surgeon online with us, Mr. Dr. Mohammed Manjra, who has extensive experience in the field. And remember, it is joints, arthritis, any muscular questions. But let's talk more on the topic, and to find out what he does is Dr. Manjra. Welcome to the studios from across the airwaves. Dr. Manjra, thank you so much for joining us.
Jazakallah for having me. Thank you.
Assalamu alaikum. So please tell us exactly, as an orthopedic surgeon, what does your title entail, your professional title, and describe your speciality in the field of body anatomy.
Okay. So orthopedic surgeons are doctors or surgeons who treat and also operate on injuries as well as ailments of the musculoskeletal system. So if you look at the musculoskeletal system, it's broken up into your axial and your appendicular skeleton. So your axial skeleton is your skull and your spine, which travels all the way down to your pelvis. And then your appendicular skeleton involves your pelvis and then your arms and your legs. So orthopedic surgeons occupy themselves with conditions of the spine and then also the appendicular skeleton. So we don't really go higher than the neck. The skull is more the domain of neurosurgeons and maxillofacial surgeons. So we basically look after the arms and legs and the spine, and predominantly most of the pathology that we deal with, aside from the trauma, is to do with the joints of the upper and lower limb.
Okay. So, and what sort of ailments are most frequently seen by you and diagnosed and also treated?
Okay, so you can break them up, primarily into those which are traumatic and then non-traumatic. So definitely, and also what type of ailments you treat will depend on the setting that you're working in. So in the state hospitals, we have a heavy burden of orthopedic trauma. So this is with regards to fractures of the musculoskeletal system. That's not to say that we don't have a lot of non-traumatic injuries, non-traumatic conditions. It's just that we don't have enough time to deal with all of it. Fortunately, outside of the state sector, predominantly we see non-traumatic or what we call cold type of orthopedic conditions. And these can be broken up into various sort of segments. So we have sports injuries or conditions, other than fractures, and these usually involve injuries to joints or muscles and tendons around the body from various sports. If you move into the older age groups, predominantly see degenerative conditions such as osteoarthritis and many other forms of arthritis due to wear away of the joints, etc. Pediatric orthopedics is a completely different section of orthopedics altogether, and that deals with either congenital deformities or acquired deformities of the musculoskeletal system, or secondary to neurological conditions such as cerebral palsy, which may manifest with musculoskeletal issues which need attendance. And then conditions of the hands and the feet, also different aspects of orthopedic surgery. So you have also some surgeons who specialize primarily in the foot and ankle or the hand and the foot. But a big part of my practice is dealing with patients with hip and knee pathology, which is where my sort of subspecialty lies. So as you can imagine, with the human body being so complex and so vast, many orthopedic surgeons choose to subspecialize or super specialize in a certain area of the body or a certain type of condition to try and optimize the care that we offer our patients.
Wow, so you really need to know every single joint of the body. So I bet you know how many bones exactly there is, and if any are broken. Of course, the necessary scans and stuff. So, any fun facts you can share with us with regards to the body structure and the makeup and the bone that we don't quite see all the time?
Yeah, so people always want to know is how soon can I get back to normal after a fracture or broken
Okay,
bone? And most people don't realize that a fracture takes about 3 to 4 months to heal.
sure.
And the interesting thing about bone, right, is that when bone heals,
Mm,
the bone restores itself with tissue that is um, exactly the same as the your original bone. So anywhere else in the body where you have an injury, you have a cut, or you have surgery, the body heals with fibrous tissue. But
yes.
when bone heals, the bone actually heals with bone that resembles your actual normal bone
Yeah.
that you were born with. So to me, that was one of the fascinating things that drew me to orthopedics, is the potential for bone to heal and for us to manipulate the healing potential and the properties of bone to
Yeah.
better um, the lives of patients and to relieve them of their pain and get them back to normal.
So you said a fracture will take about, is it 3 to 6 weeks or months? What was that?
Months.
Months.
It takes
Sure.
months. So it goes through different phases. So you have the what we call the soft callus phase,
Yeah.
is where the bone goes through an inflammatory process
Mm,
and it forms a layer of soft callus or cartilage tissue around the bone just to keep the bones together.
mm.
And then over time, this is slowly converted into actual bone, and that cartilage that surrounds the bone actually disappears. So that's one type of bone healing, and that takes
Okay.
usually on average about 4 months or so.
Sure. A lot going on, and you have to give your body time to heal. Let's start with one of the structures, and that is the hip joint. Let's look at the pain and the symptoms involved when you do have hip problems.
So when we talk about the hip, we typically talk about the ball and socket joint of the hip, which
Okay.
connects your lower limb or your leg to your pelvis.
Hmm.
And it's important to understand that your hip joint is the direct connection between your axial and your appendicular skeleton. So pretty much almost anything that you do is going to involve your hip joint. So anything from walking, sitting, getting up from the chair, turning in bed is going to involve your hip joint. As a result, any type of hip pathology is severely debilitating. So the hip joint is formed where the upper part of the femur bone connects with the acetabulum or the cup part of the pelvic bone. It sits inside the pelvis. And it's a ball and socket joint which allows you to have a very wide range of motion. So anything from flexion,
Mm.
extension, abduction, internal, external rotation, you're able to do your hip. So it's a very forgiving joint in that sense. It has a wide range of motion. And one of the most common conditions which affect the hip joint is certainly osteoarthritis.
Yeah.
Um, and generally, when you have a hip pathology, people tend to think that pain in the back of their thigh or the side of their thigh involves hip joint. In actual fact, hip pain is usually centered around your groin area. So
Okay.
we tend to tell patients that it's pain in your front pocket or your back pocket. So if it's in
Mm.
your front pocket, it's most likely to be from your hip joint. If it's in your back pocket, it's most likely to be coming from either your lower back or your spine or your sciatic nerve. And then you also have the outer part of your hip, which is the bony prominence in the side of your hip where your muscles attach.
Yeah.
And that's also a very common area where you can have hip pain or hip pathology. So just in summary, pain in the front of your hip is generally
Okay.
the hip joint. Pain on the side of your hip is generally where the hip muscles attach
Hmm.
or where your ITB runs over. And pain behind or in your back pocket is typically from your lower back or from your spine.
And you'll actually feel the pain in the hip area, or would it be different if you hurt it or if it's inflamed? Would it be a different type of pain?
No, it will be in the same area usually. It's also if you hurt it.
Hmm.
The pathology obviously can vary, either if it's a traumatic injury or if it's a degenerative condition, but typically hip joint pathology presents with pain in the groin. Also, interestingly, the human body is quite remarkable in this sense. sometimes hip pain can present with knee pain. And the
Oh.
reason being is that the nerve that supply your hip and your knee are very similar. So
Mm.
sometimes your body mixes up those signals and transfers the location of the pain to your knee. So it's not uncommon for us, the patients, to come to us with knee pain.
Okay.
And we examine the knee and it's completely normal, the x-rays are normal. But we always routinely first check the hips and the back as well. And often you find that the problem lies in the hip
Mm.
as opposed to and that's just the body, sort of in a way getting its wires crossed.
Okay. We'll continue this conversation and more of hip comes in a little bit later on. So stay tuned. We're still talking about the knee, arthritis, hip joints, sports injuries. Stay with us if you'd like to know more about orthopedic surgeon Dr. Manjra and the conversation we're having this evening. Back in a moment. Assalamu alaikum and welcome back. We're talking to orthopedic surgeon Dr. Mohammed Manjra, based out in KZN, Durban, and appreciate his time and skills on the conversation around the knees, the joints, the hip, any of the sports injuries that you might have experienced, pain, arthritis is what we will be talking about. So please do stay with us. Dr. Manjra, assalamu alaikum, and thank you so much for being with us. You are still there, sir?
Walaikum salam.
Okay.
I'm here.
Welcome back. Okay. Let's talk about the knee joint now, moving from the hip to the knee. It's more than just a simple hinge. Tell us, why does this knee joint matter in the body?
Okay. So the knee joint connects your femur bone to your tibia bone, right? And it allows you to walk with a much more complicated gait pattern or walking pattern than if you would with a straight leg, for example, right? And as you rightly said, it's more than just a simple hinge joint, because as we walk through daily life and we walk on uneven surfaces, or we kick, for example, kicking a ball or just taking a normal step, a simple hinge joint would put a lot of stress and strain around the joint itself. As a result, we have a lot of specialized structures within the knee, which allow subtle degrees of rotation, um, which allow us to walk more smoothly. All right. So, what are these structures that make up the knee? So, in all joints, you have where two bones meet each other, and to protect the bones from damaging each other, we have what's called articular cartilage. So, articular cartilage is a smooth layer of very specialized tissue, which is very slippery, and that combined with synovial fluid, which is secreted by the joint, allows our joints to move smoothly on each other, right? And this protects the underlying bone. Now, between the two bones of the knee, the femur bone and tibia bone, we have what's called a meniscus, which is a very even more specialized form of cartilage. Almost feels like a piece of rubber, right?
Mm.
And this attaches to the rim of the bones and the capsule surrounding the joint, and acts as a shock absorber for the knee,
Okay.
which is important that, in knees where they don't have a meniscus, they tend to develop degeneration and arthritis a lot sooner than patients who actually still have a functioning meniscus. So a big focus from the last 5 to 10 or 20 years has been how can we maintain the meniscus? And we're fortunate enough now to have very advanced techniques where we can actually do meniscus repairs just through 1 or 2 centimeter cuts in the knee with very specialized instruments. So the meniscus sits on either side. It's a C-shaped piece of rubber and allows the knee to have a shock absorber, or
Mm-hmm.
almost like a suspension, preventing too much contact between the bones. If you look at the knee as well, we have a very rounded convex femoral surface and you have a concave tibial surface. So we needed some stability. So we have a 4-bar sort of linkage in the knee. So on the outside part of the knee, we have ligaments in the medial and the lateral collateral ligaments on either side of the knee, which prevent it from going into a bow-legged or a knock-knee position, um, imparting inherent stability. And then you have your cruciate ligaments. So most people would probably know it as the ACL or the PCL, which prevents the knee from sliding forward or backwards. So the most commonly injured ligament in the knee will be your MCL, and the most common ligament which we operate on and tend to reconstruct is your ACL, your anterior cruciate ligament. And these ligaments are very commonly injured, not only through sport, but just through daily activities. Any sudden movements can injure your ligaments in your knee. And the important to remember is that once you have a loss of one part of these stabilizing structures of this fascinating organ we call the knee, then you lose that equilibrium and the homeostasis in the knee. And once that happens, you run the risk of damaging your cartilage that surrounds the knee. And for the most part, once you develop osteoarthritis, we cannot reverse the process or halt the process. It's something that will continue further. If there are small cartilage lesions, we can treat those and try and restore the cartilage. But for the most part, once you develop degeneration in the knee due to a loss of one or two structures in the knee, then you're pretty much certain you're going to develop a degenerative or painful joint.
Let's talk about some of the knee injuries that you've just mentioned now, and when one can pick up that there is pain in the knee. What are the symptoms that are on
Yeah.
that?
Right. So the most common, or a few of the most common symptoms that you may have in the knee when it's injured, typically with ACL injuries and MCL injuries, patients give a history of a sudden turn or a jump and they landed funny on their leg, and pain. Pain is something that is a message from your body to you to say, hey, there's something wrong and this needs to be looked at, right? The second thing which commonly happens is swelling. And the reason being in an acute injury is bleeding into the knee. Most of the time from a ruptured ACL, the ACL can tend to bleed quite heavily into the knee.
Okay.
Meniscus injuries tend not to bleed as much, but ACL injuries tend to bleed quite a bit. Other causes of swelling in the knee can be inflammation, either through osteoarthritis or rheumatoid arthritis or any other anything which can irritate the knee or can cause swelling. So, for example, if you were to bump your elbow or your arm onto something, that tissue would swell. And likewise, like the knee, if the knee is irritated or injured, it will secrete more synovial fluid and will swell up. And the third thing, or the third and the fourth thing, which patients will feel in the knee, the third is mechanical noises in the knee. Now, so not all
Oh,
mechanical noises are bad. A lot of us, if we come up from prayer, etc., we kneel
yeah.
and we stand up, we can hear the clicks in the knee, and those
Yes.
those tend to be harmless and not a
Good.
problem. But the moment those things become painful and persistent and start causing other mechanical symptoms such as getting your knee locked in a certain position and then not being able to straighten or bend the knee, then that becomes a problem. It means it's some sort of mechanical block or must lose body in your knee, which needs to be addressed. And lastly, in the more chronic setting, is patients when they develop either stiffness or instability in the knee. So two ends of the spectrum. So stiffness usually comes from degenerative disease within the knee, and instability will come from either damage to the ligaments or the meniscus in the knee. And patients will say, I just don't trust the knee anymore, especially when doing sports
Yeah.
or coming upstairs or getting out of bed. They just feel like the knee's going to give way, and that's a sure sign that there may be something in your knee which needs to be restored.
So when would you say is the time to see the doctor when you had a kneecap injury?
A kneecap injury or a knee injury?
Okay, a knee injury then. I didn't know they realized there was a difference. Please
So,
then explain the
yeah.
difference.
The thing is, in most cases, early diagnosis is better than delayed diagnosis. The reason being that if you take, for example, somebody who has a torn meniscus, we have a very short window of opportunity to be able to repair that meniscus if it's repairable, right?
Okay.
Um, if you have, say, for example, a torn meniscus and it's sitting between the bones, as you're walking, that meniscus will grind between the bones and eventually degenerate and not be functional, even if we try to repair it. If you have a ligament injury, and which is not addressed either conservatively or surgically, then the homeostasis in your knee will become disrupted, and you almost have a guaranteed risk of developing arthritis or degeneration of the knee. So the simple answer is that if you have pain or swelling in your knee and you had a recent or identifiable traumatic event, then you should get it looked at as soon as possible and not try and delay it. I think it is reasonable for minor injuries where you can still walk on the knee and there isn't much swelling to give it 2 to 3 days to settle down with some icing and anti-inflammatories. But anything that persists longer than 2 to 3 days should definitely get looked at. even if it's not something that's amenable to surgical intervention, you can get advice on how to manage the pain, the swelling, so that you don't develop um, weakness of the muscles or stiffness in the knee from underuse.
Okay. Could we move on to the knee replacements because it's a video that's coming up now? Who is a prospective candidate, or what is the best time, preferential time of the year to schedule this surgical procedure?
Right. So knee replacement surgery is reserved for patients um, who developed what we call sort of grade 4 or advanced or bone-on-bone type of arthritis in the knee. So there's many different forms of arthritis. I think the most common we will encounter is osteoarthritis, where there is wear and tear of the joint, articular surfaces or the cartilage. And then also other conditions such as osteoarthritis. So there's rheumatoid arthritis, where it's an inflammatory disease of the whole body, which can also affect the knee. And then there's also post-traumatic, as I mentioned before. If you have an injury to the ACL or the meniscus, you're very likely to get post-traumatic arthritis. So the best time to do the joint is number one, where you've got end-stage disease radiologically on X-ray, where the joint spaces are lost because of no cartilage, and the bones are now rubbing on top of each other, which is a very painful phenomenon.
Yeah.
Number two is where you're no longer responding to non-surgical measures. So we often treat patients, um, you know, for a protracted period of time. We try and explore non-surgical measures because we cannot cure the disease, but we can control the pain. So things which you can do to try and control the pain include anti-inflammatory medication, pain medication. There's various injections which you can use into the joints. So anything from cortisone injections, the special gel injections, which are now becoming a bit more popular.
Okay.
There's PRP injections, where we take a sample of your blood, we spin it out, we remove the blood cells, and we take all the rich plasma and we put it into your knee. There's physiotherapy. There's more advanced braces, which can offload the disease compartment in your knee. Um, Exercise, such as walking, swimming, yoga, cycling. We encourage patients to take up these sports to keep the knee lubricated and functional, which also helps with your pain. And once you've exhausted those measures, and you want your quality of life back, and you want to be off pain medication, that's when you should consider a knee replacement. So on the one hand, you don't want to do a knee replacement too early when the disease will still respond to non-surgical measures. But you also don't want to wait too late, where you've been immobile for a number of months or years, and you become unhealthy because from the lack of mobility, and you've developed diabetes or you've become overweight and all of that. So there's no clear time as aside from the guidelines that I've set apart. So, which is why in our practice, we take a patient-centered approach. So, two patients may walk in with, knee arthritis, but both patients may be given two completely different treatment plans, simply because of their age or the level of activity, or whether they're responding to other treatment plans. So some patients will come in and, they've already tried other modalities and they're ready for a knee replacement, understand what needs to be done. And other patients who are still in the early stages or want to explore other things, with regards to which time of the year is best, there's no real time of the year which makes much of a difference. In South Africa, we're fortunate enough to have very pleasant weather, so we don't have to worry too much about this. I did my hip and knee replacement training in Toronto, Canada, where in winter the temperatures will go up to -20 or -30.
Sure.
So, we had to be cognizant of certain patients who were living alone, for example, and needed to walk, for example, to the shops or needed to get out of the house, that, they may not have the adequate balance to walk on the ice, etc. So unfortunately, we don't have that problem. So in South Africa, I don't think there's any specific time of the year. It's more just a patient-dependent thing when they will be ready to do it. But often that coincides with school holidays. The kids are, you don't have to worry about school rounds, etc. Or especially now with the Ramadan coming up, nobody wants to have surgery, so they tend to delay the surgeries till after Ramadan. So it's a personal thing, and we're fortunate not to have to worry about the weather and the ice that we have to contend with.
Yeah, there's a saying that I can feel it in my bones that it's going to be cold. That comes up. We talk
Yes.
more on knee replacements, hip replacements with Dr. Mohammed Manja, all the way in Durban, and continue the conversation on pain, arthritis, joints, sports injury just after this. Stay with us. Assalamu alaikum wa rahmatullah. Welcome back. This is your health and wellness show. If you're watching us across the lands on the beautiful seas, remember you can do so on www.hilaal.tv. So tell your colleagues, family, and friends they can watch the show right now. Otherwise, catch our uploads on our Hilaal TV YouTube channel and we'll post that there. And don't forget to send your questions, comments, and any queries you have on the show. We talk about arthritis, your sports injury, any pains in your niggles and joints, and when they say you can feel it in your bones, is exactly what orthopedic surgeon is talking about today, Dr. Mohammed Manja. Assalamu alaikum. Welcome back, Doc. You still with us?
Walaikum salam wa rahmatullah.
Okay, great stuff. So we're talking about the knee. We want to focus a little bit more on the knee. And just before the break, we spoke about the knee replacement. We had a video up about the knee replacement, some intricate work there. Looks like when you talk about it, it's like easy peasy, but it looks rather complex. You spoke about the ideal candidate. Can we talk about the young people today and what was your youngest patient or known youngest patient to have a knee replacement and what would be that reason?
Yeah. For the youngest patient, I think who had a knee replacement was in their 40s, which is
Okay.
extremely young for
Okay.
knee replacement. Generally, we try and delay knee replacement surgery. Historically, we would wait till about the patient was 60 or 65.
Oh.
The reason being was that the implants that we had at the time, or the plastic part that goes between the metal resurfacing components, wasn't that advanced and they would wear out quite quickly.
Mm.
Also, younger patients tend to be more active than older patients and sort of want a bit more out of their knee than what a prosthetic knee would
Yes.
give them. However, that mindset is changing slightly with the onset of more advanced implants, which give you a more natural feel to the knee. Number one. Secondly, the plastic component, which historically would wear out not fairly quickly, but sooner than the metal parts, is a lot more advanced. And the third thing is that we used to use bone cement, which is still, I think, the gold standard in terms of fixating the knee replacement to the bone. Whereas nowadays we have highly advanced porous metals, which once implanted onto bone, fuse to the bone themselves, so don't have the risk of loosening as with cemented components.
Okay.
So the youngest patient, I think, was in about the 40s, and it was a post-traumatic knee, which patient had undergone trauma a number of years back, and then had an infection and developed a stiff, painful knee. We had exhausted all other measures. And because more than one compartment of the knee was affected, we couldn't do sort of a realignment procedure as such. And knee replacement was the only option. But I think the vast majority of patients that we treat are above 60. Between 60 and 80, I think, is the bulk of the patients. We do select patients who are over 80 years of age, depending on their health and their expectations. And we do patients who are below 50 or 60 years of age, depending on how bad the symptoms are, and also, what they expect. And I think a big part of the success of surgery is what your expectations are. You can't get a knee replacement and, want to go and run, a marathon or a half marathon for that matter. There's still a lot of other things you can do. You can play doubles tennis, you can play golf, you can swim, you can cycle. There's a lot of other sports you can engage in, but certainly the high impact sports are the ones that you would want to avoid. In Canada, we had patients who were skiing, downhill skiing, bilateral knee replacement. So they certainly test the extremes of the implant. They seem to be functioning well.
Okay.
But we are very hesitant of doing knee replacements in young patients. And having said that, there are other options for patients with degenerative disease of the knees who are very young. And generally, these are patients who developed degenerative disease or arthritis, who, because of malalignment of their limbs, either they are too knock-kneed or they're too bow-legged.
Okay.
And nowadays we have other modalities to treat them, such as the realignment osteotomy, where we
Mm.
cut and realign the bone and sort of equalize the pressure where, to the other compartments of the knee, in a nutshell, to try and preserve the joint. And that's been shown to be successful in not sometimes only delaying the need for knee replacement, but actually negating the need for knee replacement in the long term. So instead of just delaying surgery, there are other ways which we can actually prevent or stop the progress a lot quicker in younger patients, which wasn't available to us so uh, maybe about 20 years ago. I mean, the procedure is not a new procedure, but the way in which the procedure is done
Mm.
and the newer literature that's coming out now is very different to what was described before.
You spoke earlier about the meniscus. Tell us exactly more and why is it so important to the knee, and can it heal on its own?
Right. So there's a big drive, actually. One of the companies um, actually have annual meetings called Save the Meniscus.
Mm.
So, for example, just to put things into perspective, about 20 years ago, if you had a meniscus injury, you would just have the meniscus taken out, and we never really understood, the importance of the meniscus. And then, you know, go on a few years after removal of the meniscus, we found these patients all develop basically 100% chance of developing arthritis in the knee, which is
Sure.
so debilitating that the patient will require a knee replacement. Now, if you
Mm.
take a 20-year-old who had a simple injury playing soccer and you go in to remove his meniscus, by the time he's in his 30s, his 40s, he's got severe knee pain. He's kind of lost the prime of his life.
Yeah.
So there's a big drive now to save the meniscus at all costs and to try and do it early. And as you saw in the picture, there's various different patterns of meniscus tears.
Mm.
And nowadays we have a lot more techniques as to how to fix them because we understand the importance of it. And the importance of the meniscus is that as I mentioned before, it's a shock absorber between the bones.
Yeah.
And without the shock absorber, the cartilage kind of takes all the load in the knee, and you have less room, for those subtle movements of rotation and pivoting, and that causes early degeneration of the articular cartilage, which eventually damages the bone and leads to osteoarthritis. So, if you suspect, you injured the meniscus, or we suspect we injured the meniscus, we're very aggressive in trying to treat it. Now, with regards to whether the meniscus can heal itself or not, it depends on many factors. So the one is where about in the meniscus is it injured. So the closer the meniscus is to the capsule or the outside part of the bone, the more blood supply it has and the better chance it has of healing. The closer it is towards the inner part of the knee, the less blood supply there is and the less chance of it healing. If you don't do anything about it, then it will not heal by itself. A meniscus requires an operative intervention for it to heal. We can manage, obviously, minor meniscus tears conservatively, but serious meniscus tears, such as the Barker handle tear and the root tears, require surgical intervention and reconstruction of that meniscus. Um, Also, something that's gaining traction is also meniscus replacements, but the indication for meniscus replacements is very narrow. These are more for younger patients with good cartilage, with no arthritis, who've lost their meniscus through trauma or injury, whatever the case may be. And we take donor meniscus or synthetic meniscus materials and implant it into the knee. But this is
Okay.
not something that's routinely used, but it is an option. But it just goes to illustrate I wouldn't say the desperation, but the importance that we place on the meniscus in the knee and its function and
Mm.
role, and how drastically this has changed in the last few decades.
Yeah, so meniscus, a new word to our vocab to add in there and discuss the importance of saving our meniscus. Another condition to do with the knee is arthritis, knee arthritis. Let's talk around some of the signs and symptoms when one is suffering from knee arthritis.
Right. So arthritis literally means inflammation of the joint, and this can be due to many different causes. So how we classify arthritis is either primary arthritis or secondary arthritis, right? So some of the symptoms you'll have is pain, clicking or cracking noises, swelling, deformity in the long term, difficulty with doing activities of daily living, loss of function, and loss of flexibility, right? So in primary osteoarthritis, what we imply is that there is no underlying cause for the loss of cartilage and the degeneration in the joint, right? Um, and this is probably the most common cause of osteoarthritis. And then we have what's called secondary osteoarthritis, where there has been some underlying condition which has caused the cartilage to be lost in the knee and led the patient down this road of degeneration. And some of the causes of this can be inflammatory arthritis. So the inflammatory arthritis are a very broad um, group of diseases such as rheumatoid arthritis, lupus, scleroderma, etc. These are inflammatory arthritis as opposed to degenerative arthritis, where the body mounts a response to its own tissues. And once those tissues become disturbed, then the joint loses its stability and the patient gets a degenerative joint. Mentioned earlier as well is post-traumatic osteoarthritis. So if you've had an ACL injury, if you've had a cartilage injury, or if you've had a meniscus injury, then you're at higher risk of developing what we call post-traumatic osteoarthritis in the knee, where you develop osteoarthritis because of some injury you've had in the knee. And then there are also patients with deformities, either deformities which they are born with, such as extreme knock knees or extreme bow-legged, or they've developed these deformities through other means, either traumatic or metabolic disease, or growth abnormalities, and that places an abnormal strain on the joint. So instead of having the forces passing through the center of the joint, the forces pass through another part of the joint, and that leads to accelerated wear and tear of the joint and leads to arthritis. So arthritis is a very broad term, with its primary and its secondary causes of arthritis, and we always try and find the underlying cause. If the arthritis is not as advanced, then we try and control the underlying factors to try and slow down the progression. But in the vast majority of cases, it's osteoarthritis, it's wear and tear, it's thinning of the cartilage, and there isn't a lot that we can do to stop or halt the progression of the disease. But there are a number of things we can do to control the pain, keep you functioning, and prevent deformity. And once we've exhausted those measures, then definitely a knee replacement is the gold standard to try to get you pain-free and get you more active and get you moving again.
Okay, we need to take a break, Doc. When we get back, we finally try and move on to the hip, but there are some questions around knee and some sports injury questions as well. But stay with us. We'll try and jam back all of that in our next segment. Don't go anywhere. Welcome back. Assalamu alaikum. A very good day to you. And remember, you can catch us right now live on Hilaal.tv stream wherever you are in the world. This is your health and wellness show. Online, we have orthopedic surgeon discussing joint pain, arthritis, knee replacement. We're hoping to still discuss hip replacement as well. So keep those questions and comments coming. And inshallah, we'll send it through to Doc to give you an answer. Online, Dr. Muhammad Manja. Assalamu alaikum. Welcome back, sir. Still with us? There we go.
Walaikum salam.
Okay. So, Doc, just a quick question on the knee. I know we haven't finished completely. We spoke about the meniscus, a new word to remember and look after when it comes to our knee. Knee locking and unlocking. There was a question around that from one of our viewers. What is that? What is happening? It does seem very weird and strange when it happens. What can you do about it? What is happening to our knee there?
Okay. So locking is a very common mechanical symptom when you have a pathology inside the knee. So there's a number of things that can cause locking of the knee. So the most common is when you have a torn meniscus and that flap of meniscus gets stuck inside the knee, and then the knee can't move. Then you've got to wiggle it around a bit, and then the flap falls out of the knee, and then you can move your knee again. This tends to happen quite often until you get the meniscus addressed, or the meniscus becomes so degenerate that it's no longer functional. The second thing that can cause locking and unlocking of the knee is when you have a loose body in the knee. So when you have osteoarthritis or any type of advanced arthritis or degeneration in the knee, once the cartilage becomes damaged and the bones start rubbing on each other, and the response to your body is to grow more bone, what we call an osteophyte or bone spur for that matter. Sometimes these bone spurs can break off and then form a loose body in the knee. So if it happens to fall into the knee while you're walking, knee will lock, and then you can sometimes fall and get hurt. And then once you move the knee around a bit, it will dislodge from the knee, and then you can walk again. And this can happen time and time again until that loose body is removed or you get the underlying process sorted out. But those are the two most common causes of locking and unlocking in.
And it can happen to anybody of any age with no particular condition.
Yes.
Okay.
Yeah,
Just
it
needed
can
to check.
happen to anyone. Usually, it's obviously with the meniscus tears. It's usually preceded by some sort of traumatic injury, either twisting or fall or whatever the case may be. In the older patients, with degeneration, have got a loose body in the knee, and then it doesn't necessarily have to be due to trauma. It's just part of the disease process itself.
Okay, because it happened to me once or twice when I was making ruku and sujood, making salah, then I would just get stuck somewhere halfway there because I've had a knee locking or unlocking, nothing to worry about there. Just stand and wait till it goes away.
Well, the other thing, which is sort of extra articular outside the joint, if you get a muscle spasm, which can mimic sort of a locking of the knee,
Okay,
that's something.
all right. Good to know. All right, let's move on to sports injuries. What are the most common sports injuries that men and women do face that affects their joints and knees and hips and any part of the muscular skeleton within their body?
Yeah. So I think the majority of sports injuries that we see involve the lower limb. I think we don't play a lot of basketball and baseball. I think we're more heavy into soccer locally, so we tend to see a lot of lower limb injuries. Now, if we start from the bottom up, ankle sprains are probably one of the most common injuries that we encounter
Yeah.
in young patients in terms of acute injuries. Um, those who are very heavily into sport can develop also stress fractures, particularly around the fifth or the base of the little toe. Those are two of the very common sports injuries. Achilles tendon problems, which is the sort of a thick band behind your leg that allows your foot to press forward, are also commonly injured in sports. And this is commonly, a middle-aged gentleman who hasn't played sport for some time and decided to take to the soccer field, and then ends up with a torn Achilles tendon. If we move up to the knee, as I mentioned before, the ACL and the MCL are two most commonly injured ligaments in the knee. We do internationally, the ACL is the most commonly reconstructed ligament in the knee. MCL is quite a broad ligament, so it doesn't always need to be reconstructed. Usually heals by itself. And then meniscus injuries are extremely common, more common than I think we thought previously. Injuries to the actual cartilage, if you get an impact to the knee, a piece of cartilage can fly off or get damaged. It's also very common. And going up to the hip, we tend to see not as much hip injuries to the joint itself, but certainly muscular injuries around the hips, so hamstring strains, high adductor strains, the muscles, the inside part of your hip, quads, tendon injuries are also fairly common. When you go up into the upper body, the upper limbs, shoulder injuries, I think, probably one of the most common that we encounter, especially instability or dislocation of the shoulder, especially with rugby and other contact sports. The shoulder can become dislocated. In most cases, if treated appropriately the first time around, patients will recover and be able to return to sport. But in cases where you've had more than one dislocation, there's usually some damage to the underlying structures, which requires some sort of intervention to stabilize the shoulder. Move down to the elbows. You can get a pain on either the inner part of the elbow, the outer part of the elbow. It's an outer part of the elbow. We tend to call it a tennis elbow, commonly found in patients who've got bad technique on the forehand. And then the golfer's elbow is on the inside part of the elbow, where you get a tendonitis of the tendon there from the golf swing. In the hand also, there's a lot of tendonitis because you've got such a dense collection of anatomical structures. So anything from nerve compression syndrome, such as carpal tunnel or the ulnar the ulnar nerve can become compressed through excessive strain of the hands, tendonitis of basically any tendon, but most commonly the ones just at the base of your thumb. And then obviously, with any part of the body, we can get fractures and dislocations from contact sports or even non-contact. If you have a severe twisting injury while your leg is planted on the ground, you can fracture. You can fracture your any part of your leg. If you fall onto your arm, you can fracture any part of it. So, you have the fractures and you have also the less sort of dramatic ones that can occur. And then on the other hand, you have those which are uh, sort of chronic or overuse injuries, which we also can have encounter. And then the most severe overuse injuries and stress fractures that I mentioned of the foot can also occur in the tibia bone as well as in the hip bone.
Doc, there is very little time for us to go through the management, the stress, the inflammation, and how to best control sports injuries and how to look after it. We have to wrap up, unfortunately. It looks like we have to do a part two because we have not even touched on hips and the replacements and what happens after surgery, going back on your knees and your hips and all those joints. So we need to book part two of hips and joints and arthritis and pains and ligaments with Dr. Manja, inshallah. But thank you so much for your time. We really appreciate your last words, just quickly, to make us understand the importance of our hips and our bones and our ligaments and joints and how we can best take care of it for the upcoming months and as long as we still have it.
So I think we always get this question: is how can I look after my joints? And I think this, it comes down to your overall health. So there's two important things that we should try and do. The first thing is we should always be aware of what our BMI is. So this is your body mass index. So you take your weight and you take your height and you plug it into a BMI calculator, which you can just get off Google. And you try and keep your BMI, below 30 at least. That means that the weight that you're carrying around is not too much for your actual height. So that's the first thing that we should do, is just try and control our weight. I know it's difficult, and the BMI is not always as accurate for a lot of people, especially somebody who's very muscular. You may have a high BMI, will actually be very healthy. But BMI, controlling our weight, is probably the first step in trying to alleviate joint disease, especially of the lower limbs. And the second thing is exercise. I always tell patients this scenario that 100 years ago we never had the luxuries that we have now. We woke up in the morning, we had to go and do physical work to get water, to make a fire, to look after our shelter, to protect ourselves from predators, that kind of thing. Nowadays, we have running water, we have stoves, we have electricity. So therefore, our caloric expenditure, the amount of energy that we expend, is a lot less than what we did 100 years ago. Yeah. And at the same time, our intake of food and energy is a lot more than what we may have done 100 years ago. And so the effect is that the energy we're putting into our body is not being expended. So we're taking in more calories than we need. So you need to go and expend those calories, whether it's joining the gym or just, taking a walk every day, trying to get our 8 to 10,000 steps in. Just stay active, something as simple as getting a bike at home, just to stay active and it's not about, doing 3 hours a day or 3 hours once a week. It's more about that consistency. Saying, okay, I'm going to dedicate my time to being healthy and to looking after this body that I've been given, which is an amana, which is a trust. And I want to do, say, 20 minutes a day or 20 minutes every second day, or whatever the case may be. And, you build up from there. So it's twofold. It's controlling our weight and just being conscious of exercising more, simply because with modern life, we don't tend to expend enough energy. So we need to make an effort to do exercise, to expend the energy that our bodies are naturally inclined to do.
Thank you so much. Let's feel it in our bones and give back to our bones and our body structure with advice from Dr. Muhammad Manja. We will hopefully see him in part two, inshallah. Jazakallah for your time, and assalamu alaikum, sir.
My pleasure.
There we have it, Dr. Muhammad Manja, our orthopedic surgeon from KZN. Very, very interesting. We need to have a part two because we haven't even spoke about sports management when you do have injuries, our hip replacement, and how to take care of any injuries that we might have, knock knees and all that. So stay tuned to our next episode, which we will deal with female hormones and fasting in the next health and wellness. Thank you so much for joining us for this week's edition of Your Health and Wellness Show. Wassalamu alaikum and goodbye for now.